Assalamu alaikum. I am Professor Dr. Mohammad Ahsan Habib. I am a colorectal surgeon and working as Professor and Head of the Department of Colorectal Surgery Department, Dhaka Medical College. This patient, he was operated by me 1.5 months ago. Then he was suffering from carcinoma rectum. Neoadjuvant chemoradiation was completed. After that, I did ultra-low anti-resection and covering ileostomy. Now I am doing the colonoscopy of this patient for restoration of gut continuity. I am starting colonoscopy. Please. You can see that I am holding my hands 20 to 30 centimeter away from the tip of the scoop, and this is the neorectum. This is some granulation tissue here. Now I am proceed forward. In case of restoration of gut continuity, we want to either do distal lupogram or colonoscopy. But in case of malignant patient, we have to do colonoscopy, of course. I am this is the movement, torque movement. I am taking my rotating my big wheel towards me, and this towards right, then it's going towards right. So you can see I have to go downwards. Can you see some bleeding area, means telangiectasia? Actually, this is a feature of distal, in case of diversion colitis. So now I am at cecum. You can see that this is the appendicular area. So this is appendix. Can you see the appendicular orifice? This is the appendicular orifice. Okay. So I am now at cecum. Now it is a typical looking as the cecum. I need to go to the terminal ileum, but as this is a post-operative case, it may not be possible, but I am trying. You can see the terminal ileal opening. This is the terminal ileum. You can see that the bag is colostomy bag is hugely distended, means that the distal loop is totally patent. It is the proof. So, in this case distal loopogram you may avoid. This is the terminal ileum. Can you see? If you want to confirm in whether it is terminal ileum or not, please give water, start the water pumping, then you can see like velvety appearance. This. Okay. So, my colonoscopy is completed. Now, I am taking back the scoop. You can observe that I am now when I was at terminal ileum, I was only 80 centimeter from the tip. The difference between the colonoscopy in fresh case and in case of restoration of gut continuity, the difference is I have to also give the scoop through the distal loop of stoma. Now, I am turning the patient on lying down position, and I shall pass the scoop through the distal loop of stoma. Though I already passed my scoop through the terminal ileum, through cecum and terminal ileum, but now again I shall push my scoop through the distal loop. Actually, when I push forward of my scoop, I have multiple movement on the both hands, left hand and right hand, both hands. This is the ileum through the distal loop of stoma. As this I am passing the scoop towards the peristaltic, so it may not so easy as anti-peristaltic means through the anus to cecum. It is easier than through the opposite direction. So I have already seen that it is intact. I routinely practice this, that in case of stoma reversal, I always pass the scoop through the anus to see the patency of the anastomosis, to see the colon, the neorectum, the rectum, everything, and also I pass it through the distal loop of the stoma, and proximal loop it does not require any evaluation as there is no features of subacute obstruction of this patient. Thank you very much.